I'll be introducing in
I'm
place.
so sorry. I apologize.
No
I'm
worries.
going to introduce Janine today. Janine will be introducing our presenter. Again, my apologies, Janine.
No worries. Thanks, Elena. We are the Department of Ophthalmology here at UT Health Houston. We're a large comprehensive eye care group located in the Texas Medical Center. Today, we have Dr. Movahedan presenting on diabetes and eye health. If you have any questions, feel free to post them in the chat and we'll answer them at the end. Dr. Movahedan, feel free to take it away.
Hi, good afternoon, everyone. Thanks, Janine and Elena, and thanks for inviting me to talk about this important topic. My name is Asadolah Movahedan, and I'm an ophthalmologist at University of Texas Health Sciences at Houston. I subspecialize in the diseases of retina, but I take care of the other variety of diseases of the eye, either medically or surgically if necessary. I'm going to talk to you about diabetes and eye health. This is a very big topic, but I tried to break it down to two parts. Initially, I'll try to talk a little bit about the structure of the eye and how some diseases like diabetes, systemic diseases such as diabetes may affect the eye. And then I'll talk a little bit about diabetes and how it affects the eye. And then we're going to talk about the specific conditions which we ophthalmologists deal with in patients with diabetes. And at the end, I'll finish with diseases of the retina, which are the major disease entities that we treat in our patients with diabetes. First, I have no financial interest in the subject matter of this presentation, and I don't have any other financial disclosures. In the beginning, I would like to talk about the structure and anatomy of the eye a little bit. I would like to compare the eye to a camera. As we all have used cameras, the first part of the camera is the outer lens, which sort of looks like our cornea. It looks like a windshield in front of the car. It's very transparent and allows the light in. And the light rays come through the cornea and go through pupil, which acts as an aperture, and then hits the lens, which focuses the light into the retina. The retina is like a thin film in the back of the eye that transmits all this information through the nerve into the brain so that images would be perceived. So this could be exactly like a camera, which the light comes in, goes through the aperture, lens, and the film, and then the wire, which goes to CPU, and then the images are perceived as images. We often get this question that how do we best take care of our eyes? This is a very general question. The short answer would be when you do all the right things as for your general health, you're essentially doing it all for all other organs as well, eyes included. Things such as a healthy diet, exercise, avoiding cigarette smoking, protecting your eyes from trauma, examination and follow-up by your ophthalmologists or optometrists, and specific precautions for particular disease entities, which they may need to do other things, but these are the major things that we all have to do in order to be able to maintain our eye health. So what is diabetes? We all know the informal definitions, but the formal definition from the National Institute of Diabetes and Digestive and Kidney Disease is that a group of disorders which are characterized by high blood sugar level over a prolonged period of time. So all of us, when we eat, our blood sugar goes high, and then there are internal regulations which bring this sugar to the level that is appropriate for the tasks and the functions of the body at that time. And this blood sugar control is maintained by a variety of mechanisms. But if those mechanisms are impaired or disabled, the blood sugar level over a time period would be high, and this will affect the health, overall health. What are the common symptoms of diabetes? The common symptoms of diabetes are frequent urination, increased thirst, increased appetite, and many of us have heard that people with diabetes may develop heart disease, kidney disease, disease of the eye, nervous system, and in some acute states, maybe coma and cognitive impairment as well. There are three types of diabetes in general, and we're talking about diabetes mellitus, the most common type of diabetes. Type 1 diabetes results from the failure of pancreas gland to produce enough insulin. Type 2, which is adult onset, the cells fail to respond to the insulin which already exists, and this is the type that excessive body weight and insufficient exercise are risk factors for. There is another third type, which occurs when pregnant women without a previous history of diabetes develop high blood sugar levels. So these are the main three types of diabetes that we can classify. Diabetes has lots of effects, but major effects of diabetes is on blood vessels. The complications of diabetes are generally categorized into complications of small blood vessel diseases, which are categorized here, microvascular complications, which are seen in the eye and in retina, in kidney, in nervous system, and in nerve, particularly peripheral nerves, and diseases of the larger vessels, such as stroke, heart problem, and diabetic foot disease, for example. But how do these things occur, and what is the mechanism? So I just wanted to briefly mention what happens when one has uncontrolled diabetes. And all of these things are mentioned when diabetes is not controlled. In larger vessels, for example, here in this diagram, if you look, this is a large vessel which exists on the surface of the heart, the artery. Diabetes increases the chance of clot formation and essentially narrowing of the blood vessel, and thus it increases the risk of heart attacks or other diseases of the heart. In smaller vessels such as kidney and the eye, the way diabetes affects the vessels is a bit different. It causes the cells which protect the outer layer of the vessel to be weakened and then gradually die and disappear. And this makes these blood vessels leaky. So the serum from the components of the blood will ooze out of the vessels, and it can cause swelling, bleeding, and many other complications that we talk about later on. These are the main categories of the eye diseases that many of our uncontrolled diabetic patients may develop. Dry eye is a very common condition, but the prevalence in patients with diabetes is higher. Cataract, again, a very common condition. All of us will get cataract as we grow up, but the frequency and severity of cataract is higher in patients with uncontrolled diabetes. Other problems that may occur are eye muscle paralysis or droopy eyelids, and most important of all, or most severe of all, if you will, are retinal diseases, and optic nerve diseases are in minority. What about dry eyes? The symptoms of dry eyes are dryness and irritation, redness, tearing, sharp pain. And as we mentioned, this is a very common condition in a variety of age groups for different reasons. And the treatment options are, we could name a lot of treatment options that exist. And we usually start with simpler measures of treatment, such as lubrication with artificial tears, lid hygiene, some medications. You may have heard of Restasis or Xiadra. These are the medications which decrease the inflammation and are used when the easier methods of treatment are not sufficient to treat dry eyes. And there are other methods such as autologous serum, which is essentially the patient's, we sterilize the patient's own serum achieved from drawing some blood, and we use the serum part in a sterile vials to treat the severe dry eye disease. There are other modalities of treatment such as nasal stimulation and with electric devices which have recently been available, as well as punctal plugs, little very small silicone plugs that we put in the punctum, which is the drainage system outside of the eye. These little small openings that collect the tear, so that we plug them so that the tear would stay longer in the eye. What about cataract? Cataract, as we mentioned, again, very, very common eye problem, and the frequency is higher and severity higher in diabetes. What are the symptoms of cataract? Decreased vision, glare are among the most common symptoms of cataract. What do we do for cataracts? If it is early, usually our standard of treatment is to monitor our patient and see if we can manage the symptoms with non-invasive measures, such as giving them glasses. And if severe enough and preventing from daily activities, we may need to go and do the cataract surgery. And cataract surgery, again, the most common outpatient surgery in the US, and it has become increasingly safe and fast surgery over the past 50 years. And majority of our patients have excellent results. As you can see here, the lens in the eye is very cloudy and opaque and does not allow the light to pass through as easy as a transparent lens. And in cataract surgery, we remove this cloudy lens through a very, very small incision in the right panel, sorry. You can see this incision. Nowadays, this incision is much smaller. This is from a photo from Wikipedia. This incision is fairly large compared to the incisions which are given right now to be able to access the lens. And we take out the lens and we put these artificial lens inside the eye, which remains there lifelong, and it provides the focusing power so that the images would be focused well into the retina and maintains the clarity of the vision. So this is a very elegant surgery. As we mentioned, excellent results in majority of our patients. Eye movement problems. Eye movement problems usually in the setting of diabetes happen when there's a nerve palsy. We do have 12 as we call them, cranial nerves or brain nerves, which essentially they innervate many of the structures of head and neck. And in particular, 3 of the nerves are responsible for many of the movement functions of the eye and eyelids. And these 3 nerves could be affected by diabetes, as we mentioned, and they can, the patients can develop double vision, crossed eye appearance, as you can see in this image, droopy eyelids, or occasionally eye pain. The treatment options for these disorders, if they're due to diabetes, most of the time is observation. Many of our patients with these symptoms of nerve palsy. As time goes by, the effect will be lessened, and with observation, many gain their normal function. However, in minority of patients, sometimes surgery is necessary to align the eyes again back into the normal alignment, or correct the droopiness of the eyelid. Now, what about the retina and vitreous and diabetes? This is a big category, and this is what I deal with on a daily basis. So diabetes, more than any other structure in the eye, affects the retina. And we mentioned retina is the sensitive, photosensitive layer in the back of the eye. Vitreous is what the jelly which fills the cavity of the eye. And as we mentioned, that is essentially in front of the retina, which the light passes through and hits the retina. The affection of retina by diabetes is generally termed as diabetic retinopathy. Diabetic retinopathy could be mild, moderate, severe, or one could have the vision-threatening complications of diabetic eye disease, if it is even more severe than the severe diabetic retinopathy, if you will. So this is an image, a regular photo of the image from the back of the eye and from the retina. As you can see, there's this beautiful nerve in the back of the eye. This is the cross section of the, essentially, you'll see that optic nerve, which travels back into the brain. And these are the blood vessels which maintain the oxygen and glucose and nutrition to the retinal cells to be able to do their job. So, and as you can see, everything is perfect over here. There's no blood, and there's nothing major going on. And this is a normal retina. This is the center of the retina, which is called macula, and this is responsible for central vision. Very important. So in mild diabetic retinopathy, these little dots of hemorrhage occur, and again, this could be the only thing that is seen on examination. And these are the early changes in diabetes. And when we see this, our recommendation to our patients would be to maintain their blood sugar control, try to bring their hemoglobin A1C level, which is one of the most important measures of diabetic control, to lower than 6.5 or lower it as much as possible with consultation with their endocrinologist, internist, or primary care physicians, and continue the follow-up examination to see whether these problems will resolve or not. There's another term that we use, and that is essentially macular edema. Edema means swelling, and you can see in this picture, in these scans, that when looking at the cross section of retina, that thin layer, it's obvious that in this patient here in the right panel, there's swelling, and this essentially bump occurs because the fluid is collected inside the retinal tissue and underneath the retinal tissue. And that is one of the most significant ways when patients lose vision because of diabetes. So macular edema, or swelling of the retina. In more severe disease, which is basically moderate to severe disease, you can see more blood, scattered blood. If you can see these spots of blood over here, it is abnormal, and you can see this lipid deposition in the retina, and you can see it all over the retina. So, and here, these little dots, hopefully you can see them on the screen. These are all hemorrhage or bleeding in the tissue of the retina, or deposition of the lipid, because the blood vessels, we mentioned that they become leaky and they ooze fluid out. So even at this stage, although it is moderate to severe, most of the time we tell our patients that we really don't want to do any invasive procedure or a treatment measure, and they should control their blood sugar, try to maintain the good sugar control, and come for follow-up examination, obviously in a shorter period of time compared to a person who has a milder disease. Occasionally in a very severe disease, we may consider injecting medication into the eye, as we are going to speak later on. But what are the vision-threatening complications of diabetes? Four major categories that we're going to talk about, two of them: bleeding in the eye and detachment of the retina. The other we talked about one earlier, severe swelling of the retina, or the lack of blood flow to the retina. Vitreous hemorrhage, or bleeding inside the eye, is one of the vision-threatening complications of diabetes. When it gets to this level, it shows that the sugar control has been poor, such that those little blood vessels, which have been oozing fluid, they have been proliferating and growing in abnormal fashion. And because they're leaking and they're abnormal, they start to bleed. And you can see in this picture clearly that these patches of blood are inside the vitreous, are inside the back cavity of the eye. You can see that you can imagine that the patient's vision would be blurry from this. And this is something that many of our patients come with this hemorrhage or bleeding as their first manifestation of the disease, because before that, many of our patients do not have any symptoms. And suddenly they come with loss of vision, often severe, and now we know that it is at the level which is vision threatening. So it is already very progressed. However, we do have ways to treat these complications as well that we're going to talk about. This is a retinal detachment, and essentially this is one of the utmost severe complications of diabetes in the eye. You can clearly look at this picture and identify that this is very different from the normal, beautiful retina that we saw with the nerve in the middle and all those beautiful vessels. This is very crumbled, and all the scar tissues, you can see this whitish tissue is that scar tissue has pulled the retinal layer together and distorted the whole back layer of the eye. And you can see that there are different layers of blood down here inside the cavity. So this is very, very, very severe. And again, when it gets to this level, our treatment measures, although we do have things, but then it gets more complex and complex, and then more invasive measures need to be taken to treat these patients. So what do we do? First, second, and third things to do is to prevent all those things to happen, because essentially many of these complications are preventable. Pretty much all of them are preventable if there is good sugar control, and we put blood pressure control alongside the sugar control as well. So if we want to do one thing, is to prevent all those complications to happen. But if they happen, they need to be treated, because part of the treatment is to restore what is lost. The other is to prevent from worsening. And of course, the follow-up to be able to monitor and to be able to see where are we going with the treatment. How can ophthalmologists help in this situation? So the first thing is to be able to identify the disease and identify whether one has a diabetes or not. And if they do, what is the stage, and is there any necessity for a specific treatment options, or we can counsel the patient and suggest to maintain a better glucose control or sugar control. So first, examination is the first step, and this is routinely done through our clinics. I usually get 2 or 3 new patients with diabetes every clinic day that I have. and that the endocrinologist or internal medicine doctor, they send their patients because they're newly diagnosed with diabetes and they really want to know whether they do have any retinal disease from at the baseline of diagnosis or not, because we know that with diabetes type 2 or adult onset that we talked about, many of the patients have diabetes for a long time before it is recognized with the symptoms. So during that time, retina or other eye structures could be affected. So what else do we do other than examination? This is what we see when we take a look at the back of the eye. This is essentially part of what we see. Actually, we see a lot more and sides. But when I look at the back of the eye, this is the image that I see. But we can actually take photos from the back of the eye to be able to monitor our patients and to be able actually to show our patients how their retina look. And I find it very useful to share these information with our patients, show them the pictures and tell them what is happening and hoping for to gain some more understanding of the disease process and the fact that sugar control can actually help the disease state and to regain the health of the eye. Other things that we do is to take retinal angiography. Fluorescein angiography is the name of the procedure, and essentially what we do, I don't know if we can play this video. This is a video that it's on the web. Probably not. It's not playing from here. But I can go ahead and describe the process. So we have the patient, they get the IV line and they inject a dye, which is called fluorescein. And what happens is that when they take the pictures from the back of the eye, this fluorescein as a contrast goes into the blood vessels and shows us many of the details that we cannot really see with our eyes and examination. For example, in this photo, you can see all these networks of little blood vessels and little outpouching of blood vessels that happen in moderate or severe diseases of the diabetic disease of the retina. Sometimes in severe disease, there is a leakage, as we mentioned. So the dye leaks out of the blood vessels, and it will tell us more about the severity, and it will guide us to more aggressive treatment if necessary. Other imaging modalities that we use are OCT scans. OCT stands for optical coherence tomography, and essentially the patient sits behind a camera and we scan the retina and we see these scans of the retina that if normal, that is reassuring, or if they do have swelling or macular edema, shows us why the vision is blurry or distorted, and we will have a guide to be able to use the appropriate medication or other interventions to be able to decrease the swelling and then restore the vision meanwhile. So what are the treatment options that we use in management of our patients with diabetic retinopathy? The first and foremost is to counsel our patients to be able to let them know how important it is to control their blood sugar. Most of the time, what I will tell my patients is that no matter what we do, it is very essential that sugar is controlled, because no matter how many medications we use, no matter how much laser we use, if the disease process is ongoing and with high blood sugars, everything is going to come back and even more severe. So two important measures that we always emphasize is blood sugar control and blood pressure control. When we go one step further, retinal lasers are the procedures that we can do in office or in the surgery suits or in operation room to be able to get rid of those blood vessels and to prevent from those abnormal blood vessels and to prevent from progression of the diabetes in the eye. The other mode of treatment is the injection of the medications in the eye. And at the end, we may need to do surgery for our patients. If it is severe enough that we cannot control diabetes with all previous measures, we'll need to do surgery sometimes to restore the vision. So retinal laser is one of the oldest treatments for the management of diabetes in the retina. Essentially, what we do is that we apply the laser through the pupil, just like the image that you can see on the left. This is like a machine that we use to take a look at the back of the eye. Essentially, a very similar machine uses the laser to target some of these vessels and areas which the blood flow is not consistent, to target them and to destroy those areas. And in this image on the right panel, you can take a look and see how the laser scars look like. These are the areas which are treated with the laser, and essentially we make little burns in the back of the eye to target the troublesome vessels. The other modality of treatment is the injection in the eye. Now, this may seem a little bit scary, but this has been one of the standard treatments for many of the diseases of the eye, because simply we have been getting better and better in discovery of the medications which can be placed in the eye in a very safe manner in the office. And we do this tens of times in a clinic, in a regular clinic. And one of these diseases is a diabetic retinopathy. And what they do, these medications, they shrink the blood vessels and they make them less leaky, if you will. And again, this is the most common office outpatient procedure in ophthalmology. We sterilize the surface of the eye with betadine. We use these speculums or eyelid holders, and we inject the medication in the white part of the eye, which is called sclera, with a sterile method, a very, very, very tiny needle and a very little amount of medication that we need to do. And sometimes we need to continue these treatments on a monthly basis or different durations to be able to restore the vision. So when less invasive methods are not enough to stop the diabetes, we need to go one step further and to escalate our treatment. This is mostly when, for example, the hemorrhage in the back of the eye, which is called vitreous hemorrhage, it does not clear with the medication, and we cannot apply the laser, and we have to go and take the blood out. And the surgery is called vitrectomy, by which we insert the very tiny instrument as shown here in this picture. We go into the back of the eye and little by little suck out the blood and clear the view from the blood. Sometimes it is more advanced, as we showed in that image, and there is a scar tissue which is pulling this thin film retina off of the wall, and it needs to be reattached. So we need to take off the scar tissue, and remember, everything is so delicate and very, very fine that these surgeries are all microsurgeries and sometimes take hours, particularly for this type of surgery, to very, very meticulously remove those scar tissues without damaging other structures, to be able to flatten the retina and repair the detachment. And one other goal of the surgery is to be able to put laser while we're doing the surgery to prevent the further progression of the disease. So what is new in the world of diabetes and diabetic eye disease? So home monitoring devices are new devices that are coming about with the advent of technology. And essentially, we've had blood sugar control monitors for a very, very long time, for decades now. Other monitoring devices which are available are devices that can essentially monitor and alarm the blood sugar in a live manner, and the patients would be aware of their blood sugar level at whenever they want to know about it without even sampling. The other devices are some of the cameras which they can take pictures and report it to the doctors so that they would identify whether there has been any progression or not. The new technology and artificial intelligence is coming to our help to be able to transfer information between clinic to clinic or from underserved areas to larger centers to be able to better serve our patients. In addition, there are new generations of medications for management of diabetes. There are all sorts of advancements in regenerative medicine, hoping to treat the origin of diabetes, which is essentially developing sources of cells to secrete insulin, and from a pancreatic transplant to other sorts of measures. In addition, in terms of ophthalmologic advancement, there are new medications which are becoming more available, that they last longer in the eye and decrease the treatment burden. And in addition to that, there is always technological advancement in terms of instrumentation and techniques to be able to restore the retinal structures, if you will. So these are some of the useful links that could be used to gain further information in this regard. And I'll end with our information. If you want to get more information about the services and or to schedule an appointment, these are the contact number for us at Cizik Eye Center at University of Texas Health. Thank you very much for paying attention, and I'll open up the floor for any questions.
Yes, so we had a few questions. The first one was, what eye drops do you recommend for dry eyes?
So dry eyes are, as we mentioned, dry eyes are very, very broad category of ocular surface diseases. It's very common, and we typically escalate the treatment as we move on. Many of our patients use artificial tears. What I say to my patients all the time is to avoid using drops such as Visine and anything that says takes the red out. Those are the medications which your eye or and particularly ocular surface can react to, and things may get worse actually. Any type of artificial tear could be helpful. There are a number of categories, but the majority of the eye drops for dry eye, we're talking about the artificial tears, not the medications themselves. But artificial tears can be categorized into two different categories. The ones that they have preservative, or the ones which are preservative-free. The preservative-free artificial tears usually are kept in little vials that when they're open, technically they shouldn't be used more than 24 hours, and sometimes they could be kept in the fridge because they're preservative-free. The ones which are in larger bottles, most of them are have preservative, and the difference is that the ones which are preservative-free are more gentle to the eye and generally could be applied more often, as much as the patients are willing to, maybe every hour if it is needed. And some of our patients really do, and they feel that their eyes are feeling better when they wet the eye every hour or every 2 hours. But for some people, it's very difficult to put the drops every hour, or they simply forget. So the preservative artificial tears, the ones that have preservative, the recommendation is not to treat more than 4 times a day, because the preservative itself can cause more dryness. So any type of artificial tear should be okay to use. I don't have any specific recommendation. Anything that it really doesn't matter if they're brand name or not. Paying attention to see if there are some people have more sensitive eyes. So for those folks, I'll suggest to use preservative-free artificial tears more so.
Awesome, thank you. Next question we had was, does blurry vision from diabetes go away?
It really depends from what is the mechanism for that blurry vision. As we mentioned, this blurry vision could be because of the dryness. Most of the time with this blurriness with dryness is very instantaneous, and with blinking or using artificial tear, it goes away. It could be because of progression of cataract. Then there might be a need to change glasses or go through surgery for the blurred vision to be restored. Or it could be from the retina. As we mentioned, swelling of the retina is one of the main reasons our patient's vision would be blurry. Other than that, other complications can cause the blurry vision as well. So it really depends at what level the problem is, so that we will address it at the same level.
Great. And our last question was, what is the recovery time for injections in the eye?
So these injections, the injections that we do, most of our patients tolerate it really well. We numb the surface of the eye and we do these injections in the office. And right after the injection, many of our patients prefer to not be so much active, and they usually go home and rest afterwards. But I've seen some of our patients who continue to work and they continue to do their daily activities. The eye might be a little bit irritated because of the betadine that we use, and might be a little bit red, but overall they shouldn't have any significant problem. There's not that much of recovery, and I would say for most of our patients, the next day everything would be fine, and we don't expect any issues. Although sometimes the redness might linger a little bit longer, but for the most part, I think the next day should be fine.
Great. I think those were all of our questions for today, but if anybody has additional questions or would like more information, we put our contact information in the chat.
Wonderful, wonderful. Well, I really want to thank the doctor today for this wonderful presentation. It's rather informative. And of course, as always, thank you so much to UT Health Neuroscience for their support. We just couldn't do it without all these wonderful opportunities to learn and to be engaged for better health. And that's what we all want. So everybody stay warm and have a wonderful weekend. And thank you so much again. Bye-bye now.
Thank you, everyone.